Thank you for inviting, and it's exciting to see endoscopy being talked about on the main stage. So today I'm going to talk about the biportal techniques. And before I get in, what is a biportal surgery? So the diagram A is kind of like your paramedian tubular surgery, where you stick a very stiff tubular retractor, and you're confined within that area to do surgery. So you often have a microscope, or you can use a loop. But the limits of your instruments are limited by the diameter of the tube that you're placing. What you saw with Dr. Jensen and Osama was that uniportal surgery in C, you have a very small camera, and then you have a working channel above. So still, you're limited by the confines of your approach. What biportal does is it decouples the camera from the tools, so you actually enter at the different skin, and you get to the pathology. So this is the typical endoscope, and diameters are about 7 to 8 millimeters in size. The working channel above it is about 4 millimeters. So these are all the tools that are not familiar to the neurosurgeons or spine surgeons. You're all of a sudden limited to a 3 millimeter drill bits. You're using a 2 millimeter kerrasons. I like using 4 millimeter kerrasons and fives when I do laminectomies. So you sort of have to change your workflows quite a bit. And this is the picture of your uniportal versus a biportal. So on the left, everything's working in a straight line using a small tools. On the right, because you're making a separate incision, you can bring your typical tools. So these are the things that I like to use when I do discectomies. I like using upgoing curettes. I like using downgoing curettes to push down the disc fragments. I like using a nerve hooks and the kerrasons. And these are all the tools that you cannot use when you do uniportal, but biportal allows you to do that. So uniportal really started out doing a medial branch blocks, discectomies transforaminally, but it's really difficult to take that limitations to tackle all these other really complex things. But biportal, because you're using a familiar tools, you can start to tackle these things. And like imagine I love eating a bowl of pho, but having it with just one hand with the fork, not so much fun. So can you tackle these things using a biportal technique? Of course you can. And I think these are the things that we don't really talk about. The uniportal systems that are on the market are about $250,000 to start. And biportals, because you're using tools that are already in your system, the shoulder scopes, knee scopes, so bigger patients, hip scopes, these are a fraction of the cost. And so what do you actually need to get started? You can use a 0-degree scope, 30-degree scopes. If you have a sports in your hospital, most of them will carry the 30-degree scopes. But 0-degree scopes, again, are not that expensive to buy. And these are drill bits. If you buy from India, you can get it for about 65 cents. And the radio frequency probe, these are shoulder and the knee radio frequency probes that you can use. These are readily available in your hospital. Each of them is less than $100. And these are typical things that I use to do the biportal surgery. Again, these are all the standard tools, Woodson's dissection tools that are available. And this is what I use for a transforaminal lumbar inner body fusions. So the most tricky part about the biportal surgery is the targeting. Because you're converging at two separate incisions on the skin, and you have to converge at a certain distance away. That's often the most trickiest part. So when you first start out, you want to mark out the disc space on the AP, get a perfect shot, mark out the disc space, midline, the mid pedicle, and enter at the skin, and you want that tip to be converging at the disc space. So there's all this. My goal presentation today is not to teach you how to target, but that's the general concept. You want to enter on the skin and converge at the target, and you want to get a perfect triangle where your tools are converging at the tip, but not crossing over, or your skin incisions too far apart, and your tools are not meeting at the tip. So you can sort of practice that using a spinal needle and then getting that perfect trajectory. And this is how you want to end up. You want to hold the scope I'm right-handed, so I always hold the scope on the left hand, and then you want to come in with the tool on the right, and you want those two tools to be converging on the top of the facet joint, or converging at the level of the disc. So just quickly want to show, after I do that approach, there's a dilator just like the metrics tube you're placing, and that's the trocar, and then I'm actually making sure I can feel the two tips underneath the skin, and that's how you get started. So I want to show this case at the end just to demonstrate how far can you push the bipolar endoscopy. So this is a 57-year-old female presenting with a intractable pain in the anterolateral thigh. Try all the conservative things, but no weakness. This is the imaging. She had a L3 foraminal mass that appeared to be a schwannoma. And you can see this is a contrast image. So you can do it many different ways. Decided to do this endoscopically. So I'm going to show quickly a video. How do you do that endoscopically? You place her in the Wilson frame. I like to flex to open that up. And here you're actually converging extraforaminally. So that's actually the transverse process. And again, I'm using a diamond drill bit and upgoing curettes. And drilling the pars and then the bottom of the L3 pedicle, and that's the tumor, and you can readily see it. And I'm coagulating and opening that area. Again, this is what it looks like. I'm converging from the skin and drilling the bottom of the pedicle of L3, and then sort of opening that area over that tumor. And once I open, there was a plane that was available. So with the biportal surgery, you are actually using a bimanual dexterity, and I'll show how we did that. And using that Woodson and Penfield 4 to develop the plane around the normal nerve and the tumor itself.
That's correct.
And you can see, because the constant irrigation is sort of like your third hand, and as you develop the plane, it actually dissects the tumor away from the normal the nerve. So here, after I mobilize it, and we pulled out the what appeared to be a schwannoma, and afterwards, here's the versatility with the biportal. I had the I call this triportal. I had my assistant hold a scope. I made a separate incision. I brought in two dissecting tools, and because I wanted to inspect inside my resection cavity, and that's actually the inside look of the nerve after the resection. She had a reasonable outcome afterwards, and this is the post-op imaging afterwards, in showing that the tumor was gone. So I think pushing the limit with the biportal endoscopy, it gives you that bimanual dexterity. It doesn't cost a lot of money. You can actually do real cases, infection, trauma, separation surgeries. So thank you so much.